Thank you, Patty. Thanks. And Caitlin and I are actually going to facilitate this discussion together. We're just going to kind of, Caitlin has worked in this area for quite some time and has a lot of the history and background of how we got to this point. And so as I go through the slides and presentation, I'll circle back with Caitlin to make sure I didn't miss anything. And she has a lot of great information to add. So we're going to kind of tag team as we discuss the One Utah roadmap as it relates to the social determinants of health. So let me try to navigate. Okay, so can you, I'm assuming everyone can see slides. It's so hard to, yeah, because with Zoom, you can't see what you're presenting. So the Lieutenant Governor had the opportunity to review the One Utah roadmap in a little bit of detail. And we are going to focus primarily on the health security section, specifically the social determinants of health. As you can see here, the vision is to be a state where residents are happy, safe, healthy, and successful, a place where we can grow old surrounded by the people we love and live peaceably in the most beautiful state in America, a place where we realize the good that comes from doing things together as one Utah. And it was mentioned earlier too that there's 6 strategic priorities to be addressed within the first 500 days. And when you think of 500 days, you know, for me, I'm like, oh, that's a long time. But really this fall, September 10, that's our 250-day milestone. And our 500 days is May 19 of next year. And so when I think of it that way, I start to panic. Like, we have this monumental task to meet these objectives and these activities over the next really year. So you can see here that the social determinants of health falls under health security along with combating COVID. It has here value-based care and transparency and access to care as well. So I just wanted to share quickly who the leads are for each of these areas, just so you're familiar with it. You could see here, Tracy Gruber is the Executive Director of the Department of Human Services, and she is the lead for access to care and social determinants of health. And then you could see Rich Saunders from the Department of Health, Executive Director for Value-Based Care, and then Commissioner Anderson from Department of Public Safety for combating COVID-19. And so for each of these areas, we also have, I guess, co-chairs or to help kind of move this work along. And so for each of those areas, you could see who is taking the lead in those efforts. And that's where I fall under social determinants of health, as well as Bill Krim from United Way. He was the president and CEO. The way they set this up is that the chairs consist of a state employee and a non-state employee. So it's really great to be able to work with our partners and bring broader perspective into this plan. We also get a lot of support from Stacy Nime with the Department of Human Services and Nikki Campbell from the Department of Health. Okay, so in the original One Utah Roadmap plan, which you can find online, you'll notice that under social determinants of health, it did have transition to value-based approach to healthcare. And under value-based care and transparency, there it had develop reports and action plans on racial and ethnic health inequities and disparities, and these have switched. So when you look at the original plan, it may not reflect the way we're working on this plan now. So we were able to have some flexibility to align a little bit better as we started looking and working on the plan. So I just wanted to point that out because it's not the same as the document that you'll find online. So just kind of moving into specifically the action items under the social determinants of health. So we have 3 of them. Identify and invest in priority services and infrastructure that impact the social determinants of health. develop a statewide health equity plan charged to evaluate systematic changes that address health disparities, and then develop reports and action plans on racial and ethnic health inequities and disparities. So for now, I'm just going to briefly focus on the last two boxes related to health equity and racial and ethnic disparities, and we'll provide a little bit more background on the first box related to the social determinants of health infrastructure. That's really, really complex, and so we'll go into a little bit more detail. So just for a little bit of context with the last two boxes, there is a current plan developed by the Department of Health, Office of Health Disparities, that needs to be updated. And in another breakout session, they're sharing and discussing a health equity framework that they've developed and how organizations can use this tool. And currently that office also has a website with reports. It is fairly limited to specifically items that the Department of Health has worked on. And we're interested in learning more about these efforts around health equity and intend to leverage the work that is currently happening and that exists within the Office of Health Disparities, but in addition to the other group, Equality and Opportunity, is another strategic area of the One Utah Roadmap plan that is also working on health equity. And so we don't want to recreate what is already happening. And what we really want to do is leverage what's happening and see how we can kind of pull this together as a statewide effort. So with that being said, there's still a lot we don't know as far as community stakeholders of things that may be happening that we should leverage and maybe have conversations around. So I really want to open it up to all of you to talk about this. And when if you have something to share, we'd really appreciate if you could just say what agency you're from and quickly introduce yourself. We didn't get a chance to go through introductions because our group is so large and we don't have a lot of time in this breakout. So I have some questions here just to kind of, you don't have to stick to these questions necessarily, but just to help us kind of think of what deliverables might look like for these action items on the One Utah Roadmap. And so under develop a statewide health equity plan charged to evaluate systematic changes that address health disparities, what does this look like to you? And are there existing plans that we should be aware of and potentially leverage? And who should be at the table with these discussions? And then when we think about the reports and action plans on racial and ethnic health inequities and disparities, you know, we've thought of developing a health equity action team. Who should be involved in that? How do we make sure that we have cross-sector representation beyond health? What would their role be? Does something like this currently exist? And then thoughts on a repository of reports, because we do have a placeholder or a website with the Office of Health Disparities. But again, you know, do we need something bigger and broader where we can collectively go to find information and reports on health disparities? Where would this be housed, or how else can we approach this? So I am going to pause there, and I would love to hear your thoughts and suggestions and engage in a discussion around some of this. So I think we could just kind of jump in. Hopefully we won't talk over each other.
You know, Anna, Dave Cook from Comagine Health. The first thought that comes to mind when I see this is a project we worked on years ago around chronic disease in chronic kidney disease, diabetes, where, you know, African Americans have, I don't remember the statistics, but 3 times more prevalence, and Native American Indian Native Americans have, you know, 4 or 5 times higher prevalence of, and as I see this, I'm wondering, I know, I mean, we were doing quarterly reports on the disparities through this statewide project for those years, and I think it would be chronic disease might be a nice area to, because I think we probably have historical data in our state that we could trend some of the health equities in different disparate ethnic racial groups. And, and, and in that project, we certainly did some extra interventions in the tribal, in our tribal avenues, and also in, other disparate groups based off of what the data was showing us. So that might be one place is with some epidemiology work.
Thank you, David. Do you know where we could find those reports, or which maybe program worked on those?
No, that's a good question. I mean, and this was probably 5 or 10 years ago. Most of this was based off of claims data. That's what we were utilizing, and I don't remember how we matched to. I'd have to work with some of our analysts to see where some of those reports. I mean, we were working with. I mean, we're the quality improvement organization for Medicare, so I mean, we were working with Medicare data in that project. But I've got to believe there's probably different areas of, could we look at the APCD data for some of that? Could we look at BRFS? So I mean, there's probably different avenues that we could look at there.
Thanks, David. I appreciate those thoughts. Anyone else? And feel free to also use the chat, though I can't see it. So I don't know if anyone is putting.
There's nobody in the chat, but I do have a comment. This is Linnea Fletcher. I'm with the Utah Department of Health, and I'm the program manager for the EPIC program. We've been working on a health equity action plan and did come across one from LA County that did a decent job of breaking down what their data was and examples of their health equity action plan. But as far as the question of being brought to the table as well, this was a discussion that we had probably 4 or 5 months ago with partners as well, just as we were working on our strategic plan. And the comment that came from a number of them was that we need to be looking at health equity and equitable society in a little different way, that in the way that we convene groups together, that a lot of times they don't come to the table because they're invited to every table. And so how is it that we can reach these communities that need to be brought to the table in a different way than what we've previously thought? And so where we have Zoom or we have lots of meetings previously in person, that they're spread very thin. And so a lot of times those voices aren't heard, and that we need to change the dynamic of how we're thinking and how we reach them and do it in different ways than what we previously have done.
Have you guys thought of maybe some solutions to that, or other ways to engage?
Yeah, one of the ways that we're currently doing it is with, we're calling them engagement groups, and partnering with the University of Utah on it. And so having engagement meetings with them that are a little bit more focus group related, going to meetings where they're already at, discussing it with them in that way, doing surveys within the community. And I know that communities are really surveyed out at this point, especially with COVID. So it's just finding ways to engage with them. So we're planning on, we've got some things set up for the end of June to kind of help with reaching some of those communities, and those engagement groups are being run, like I said, with the University of Utah.
Great, thanks so much for that, Linnea. Any other thoughts from the group on kind of what this would look like to you?
One other thought on this too, this is Dave again from Comagine Health, is Utah is kind of unique in that we do have a lot of organizations to partner with. And I don't know, I mean, it would be good to compile the list of various associations, there's a Polynesian group, there's some Hispanic groups that could help us as we try to create culturally sensitive and messaging and interventions. And I've worked in some other states where there's just not many people to partner with, but I don't know all of them. There's probably somebody on the call that may know more of them, but we at least ought to create a list of folks that we should be partnering with, and to be able to jumpstart some of the efforts, because we'll get a lot further down the road if we're working within a organization that's already connected to the groups that we want.
Right. And community health workers come to mind. And I know there's another session going on right now focused on community health workers. I'm not sure if there's anyone in this group that might have some information or would like to share about maybe how we can engage with community health care workers and I guess like if there is a contact list so that kind of those requests are being directed and filtered through a leader in that group, especially with Linnea mentioning that some of the communities are extremely overwhelmed with being invited at the table, but how can we help with that? And it's something that we definitely should connect with Tessa on, in addition to others, definitely Dulce. And Nubia is another individual that we are working to connect with to make sure that we don't duplicate some of these efforts that have been charged to our group related to health equity and racial and ethnic disparities. Okay, any other thoughts or questions before we move on?
Hey, Anna, this is Mike. And as some of you may know, at the health department, we're trying to develop our version of California's Healthy Places Index website. And if you haven't, for those of you that haven't seen that, you should take a look. It's really an amazing tool that not only shows social determinants of health at small geographic levels, but it has evidence-based policies that have been known to be effective to address those social and economic factors. And so I guess what I think is a health equity plan needs to have a strong surveillance system so that we can really measure where the vulnerabilities are, use that for targeting, and over the long run, be able to measure our impact or success addressing those social determinants of health. We have begun identifying indicators that we could do at our small area level. And I think there's a tricky balance between inviting all the partners to help with indicators or starting with here's what we think are the initial list of indicators. Now let's add to it by going to partners and what else would you like to see? I mean, the ones that we chose to start with are education, household income inequality index, unemployment, adults without health insurance, hospital admissions that could be effectively treated through outpatient care, food insecurity, households spending more than 30% of their income on housing, violent crime rate, and access to public transit. Those are the 11 indicators that we agreed across the department to begin with. And again, I know you don't want to, I don't mean for this to be a big discussion about what indicators, whose favorite indicator did we not include, because it's only a starting point. But I think the plan, we can't just start throwing out changes until we know where the changes need to occur and how we can measure over time that they're effective. And then I think it also addresses the repository of reports too. In this age, I think throwing a bunch of PDFs on a website is sort of an invitation for people to not read them. And having something like the Healthy Places Index dashboard where it's up to date, it's interactive, people can zoom in on their neighborhood. It just seems like a better solution than a bunch of static reports that by the time they're published are 2 years out of date and sit on a website until they become a broken link somewhere. But those are just my ideas.
Those are great, Mike. And I have been thinking about how to make sure we are connecting the Healthy Places map to the work we're doing with social determinants of health, and how that can inform, right, that work. And then also the 211 counts. We've been fortunate to be able to partner with 211, who's working on, if you haven't looked at 211 counts, you should. It's such a great system to be able to look at several different indicators and referrals and needs in the community. Right now it's by zip code in Utah, but we are working on getting that displayed by Utah small area, which is what a lot of our partners are familiar with in this state, especially the local health departments. And so we're really excited about that. I guess just wondering how those two, the Healthy Places map and 211 counts, can complement each other, and how they can be used to help inform the work that we're doing. But yeah, great comments, Mike. And I'm glad you brought those tools up, because it's something that will be a great resource as we move forward in this. When is the anticipated release date of the Healthy Places map?
When we get it done, yeah, we've been working with the AGRC on a low budget version. I mean, California spent $2 million on theirs, and we put in about $20,000, and but now we're able to leverage some COVID funds, a substantial amount of COVID funds, and so it's my hope that we're going to put out an RFP, get a really good vendor, and build something that looks more like California's website. But I can't give you a timeline on. I don't know. Think when you think it's going to be done, and then double it, like most things.
Can I jump in on just something to throw into the mix? Is that the UDOT, they call it the prioritization model, but this is the way in which the Utah Department of Transportation makes decisions about what transportation projects they're going to fund. And, this is a lot of money. We're talking about $700 million a year. One of their criteria is public health. And so they're looking to see how projects and communities are working, in other words, social determinants of health, to affect public health. I bring this up because I think that, UDOT planning, but also transportation partners can potentially partner on this great idea of mapping out social determinants of health, helping to unpack how communities are doing on this. And I mean, I love this idea a lot, that if we can get these GIS layers and maps and information out there, make them really visible, explain to people how they were developed, that maybe we can get more people thinking about social determinants of health and how they can, within their communities, improve these things.
Absolutely. Thanks, Ted, for chiming in on that. Yeah, there could be some potential for us to connect further and have broader discussions about what you just indicated regarding the priority areas and public health being one of them. But I just wonder if there's opportunities to incorporate, I don't know, Mike, if there is public transportation within the healthy places now. I don't know. There's some thoughts there that maybe we could explore, or access to public transportation.
I mean, percent of population that lives within the public transportation access is one of our 11 initial starting indicators. And we're getting that from the AARP livability index. If there's a better source, it would be great to know that, but that's what we've been able to determine that we could do at the small area level. We're really committed to the small area level because our small areas are communities that have policy and environmental jurisdiction within those communities. And it really makes more sense to me to focus on small areas than census tracts or zip codes or some other arbitrary geographic boundaries.
And I know we probably don't want to go down the technical rabbit hole, but there's a bunch of data that we have that I think is way better on that that we can provide. And I just wanted to just note that I'm personally not just talking about public transportation. I'm talking about all transportation, bike facilities, roads, but also land use. You know, even though this is about transportation funding, what I was getting at, I think it's saying to communities how you do on public health across all of those social determinants of health is part of what makes sense for us to think about how we spend money in Utah. And so it's basically just a really good carrot for us to get more people interested in social determinants of health broadly.
That is wonderful. We will make sure that we connect with you, Ted, especially as we think of some of the data sources that we're using and how we can best incorporate this into the work that's happening. So thank you for bringing that up. Okay, before we move on, I just want to see if anyone else has anything they may want to add or contribute. And feel free to send me an email, or Caitlin, if you do have anything that you come across maybe later. Okay, let me make sure I can. Okay, so thanks. Yeah, thanks for that feedback and information as we, move towards our goals in the next 500 days. Okay, so I'm going to shift to that first box where we were looking at, as an action item, identifying and investing in priority services and infrastructure that impact the social determinants of health. So I think everyone's familiar with this public health framing of individual, community, and systemic factors that contribute to the social determinants of health. So I'm not going to spend a lot of time on that. But really, what we're looking at is focusing on the personal level to develop technological and personal infrastructure to support individuals. And this could look like a lot of different things. So we established a social determinants of health committee with the hopes that bringing this group together, and some of you in this breakout may have been involved in that meeting yesterday, but the hope is that these individuals would also reach out to their broader networks to engage in these conversations around this infrastructure possibility in looking at social determinants of health. And what we want to do is build broad consensus from every sector. So we met yesterday and started having these discussions to really set the foundation, build rapport within the group, and then explore the different approaches. And you could see here just kind of the entities that we're looking to engage with. And we know that there are gaps that we need to fill. Caitlin, do you have anything to add to that?
No, I think that sets it up. If you want to go to the next slide, I'm happy to sort of talk about. So the background that many of you, I recognize a lot of familiar names and faces on here, is that there's been a great deal of work kind of going on throughout the state already to try to address social determinants of health, but a lot of it has been in really sort of siloed ways. So there's just a sampling of logos here on the screen. Some of you might recognize. The CHI, for example, is run by the Utah Health Information Network, transmitting health information data across different health systems. There's the Social Services Blueprint Project that's been going for now the last couple of years, trying to better connect care coordinators across different state sort of level services, from corrections to human services to workforce services. Many of you are probably familiar with the platform Unite Us that's being used in a pilot through the Alliance and set up by Intermountain in a couple of communities across the state. So there's just a lot of work that's kind of going on. And United Way and 211 and others have been involved in these conversations for a few years, trying to figure out like how do we create a unified structure and system in order to help, as many people throughout Utah get connected to the services that they might need. But to Anna's point in the image on the previous slide, right? Like we know that there's things at the system, the policy level, the community level that also need to be addressed. But this has sort of been the place that people have a lot of energy around sort of starting. It's like, let's get our hands kind of wrapped around the different apps and platforms and systems that are already out there, and sort of been this conversation about like, could we approach this in a different way? Could we create a unified solution? So Anna, if you want to go to the next slide. This is again with the group that we met with for the first time yesterday, sort of presenting like the couple of different options, right? So one is we could stay kind of as we currently operate, and that's that there is multiple systems and platforms that don't necessarily share information across organizations and sectors, or do so in limited geographies or in limited capacities. Alternative one that we've sort of proposed, that some other states have adopted, other communities have adopted, is going kind of the single platform route. Many of these sort of third-party companies have really started up. They're all very young and new in the last few years. And many of you, may or may not know that I think a lot of that was really instigated and kind of started from the healthcare community. And I think we're trying to really take the approach with this new committee and the structure under the One Utah Roadmap is yes, including healthcare for sure. And also, wrapping in a lot of the other sectors that serve vulnerable populations as well. So alternative one being like that single platform option, with the hope that maybe there would be future interoperability to integrate with current systems that are already in place. And alternative two is sort of a term that's been coined by San Diego, who started a community information exchange. And really this is sort of what they call a technology ecosystem that allows for lots of different platforms, systems to sort of operate together through getting everybody to sort of adopt common standards, protocols, and infrastructure and governance. So those have been sort of the two leading ideas that have been put out there. Would love to hear from this group if there are other options that you've heard of, or think that the group should consider. But this slide also does a nice job of sort of laying out in terms of sort of different features of the different options, from what's considered the network, like who are those network partners? Would that be, the current, again, is sort of currently siloed, or there's pilots of networks, but it's not statewide, versus being centrally coordinated, if there's shared language and how critical that is or not. The technology, again, and sort of being either system agnostic to welcoming lots of different technology, whether it's homegrown, other platforms that are out there that people are already using for care coordination or referrals. and then the resource database, and as well as sort of community care planning. And I think this really relates back to sort of the previous conversation we were just having about how do we sort of know when there's needs in certain areas? How can we sort of more, 2-in-1 has been kind of our maybe best barometer for where the needs are. And that, as Anna mentioned, that 2-in-1 Counts website is a great tool to sort of seeing where that's popping up and where the gaps might be. But that's also just limited to the folks that connect with 2-in-1. We know there's a lot of other folks connecting directly with service providers out there. And so the hope, I think, is that the statewide infrastructure can help us really gather data in a more comprehensive way to ultimately let us better plan for the services and address the gaps that might exist. So I'll pause there and see if there's any questions, comments from anybody. Okay, hearing none. I think the other piece of this that's up on the slide now is also related, I think, to Mike, your comments, others, is that one of the pieces that we've tried to get all of the stakeholders to hopefully come back with at our next meeting is to identify, we have a lot of cross-sector folks, and for healthcare, what they sort of care about, especially on this individual level of connecting people to services, might look like those avoidable emergency department visits, or I don't remember the phrasing used, Mike, that was really great too, about sort of like things that could be seen in primary care or out of a hospital system. Might be one. Another one for like the Department of Corrections might be reduced recidivism rates for people that are entering back into the jail or prison systems, by hopefully getting them connected to the services that they need once they're released. So we're really looking for, again, aligning back to the One Utah Roadmap vision, to get sort of all of these different sector partners to hopefully help us identify what those population level indicators would be, so that as we create whatever system for the personnel and infrastructure support to connect individuals and keep them, healthy and thriving and stable, what are those population level indicators that we want to see change and move over time? So would love to hear any thoughts anybody has. Otherwise, I think we have a list of like a few questions too about sort of hearing those couple of options that we're looking at in terms of like a one platform solution or an interoperability community information exchange solution. If either of those speak to you more than another, what concerns you might have, additional efforts or platforms out there we should be aware of, how we can better involve community members. Yeah, just open it up. I think we've got about 9 more minutes left in this breakout session, so would love to just open it up for discussion from anybody. Or Anna, if you want to add any additional comments too.
No, you did a wonderful job going through those slides. Yeah, so we would really love to hear any thoughts or feedback about the approach we're taking related to that first action item related to the infrastructure needs with social determinants of health.
Oh, one thought on this, Caitlin and Anna, is I know various states are doing different things. For example, in Idaho, I think they're committing around, I think the product is Aunt Bertha, and I know in Oregon they're more in the Unite Us platform, and other states are. Have we chronicled kind of a little bit what's happening with states around us? And there may come a point where we want to expand this cross state borders a little bit. Anyway, just a thought on that.
Yeah. That's a good question, David. I think we're trying to understand what we're seeing in Utah and the different platforms that are using, but definitely looking, with other states, and what makes that complicated is, how can they talk to each other, or how, you know, are they interoperable? And so, so that's kind of that's the current state we're in, with looking at these different platforms. With the first alternative, investing in a single platform, I think some of the concerns that I've thought about are, if we did do an RFP and we did pursue a single platform, would agencies that are currently using a platform switch to that platform? And if not, how could we hope for interoperability at some point? Or then are we still just kind of operating with multiple single platforms?
No, it's and Intermountain Healthcare is already kind of committed to one platform, if I understand my conversations with them to some degree. And I mean, and as much as they represent 60% of healthcare in our state, roughly, to what degree do we, are other healthcare entities going to go a different direction, or is it easier to coordinate with Intermountain based off of the platform they've chosen? Those are some thoughts that kind of come to mind in the conversation. I mean, the interoperability battle is one we're in the thick of, and we're I don't know that we're, some days it's 2 steps forward, 1 step back in that framework, because there's market forces that that sometimes we fight against, but
Right.
no, I'm very much in favor of this, and I mentioned yesterday on the call too, there's so much work on the front end of this to be able to bring it into the healthcare system in the screening side of it. The social determinants of health screening in healthcare settings is relatively new, and is just starting to get a little bit of traction. And how can we promote some of that? How can we make it easy to a healthcare system that's very burdened, to make it easy to do some of the screening, to be able to, no matter what, whatever we determine out of this project, but how do we make it so that they want to start screening and start using these tools and initiatives is some of my concerns.
Dave, I think, yeah, you're right. Intermountain is piloting Unite Us in a couple of communities or a couple of counties in the state. We know Stewart also uses Aunt Bertha. And to your previous question about other states, like North Carolina has adopted Unite Us as a state. Arizona just adopted NowPow, I believe. So there's lots of vendors out there. And I think that complicates, as we think about, people who do live close to borders and might go to different, places across state lines. Some of these systems are multi-state, right? So there's a lot that we need to really think through. But I think the other thing that we're really thinking about too, and you make a great point about healthcare, like healthcare is really invested in this, and can see a value in connecting their patients to services. But there's also a lot of state state agencies through the Blueprint, the project that I mentioned, that are really interested in the referral part, like how do we connect people to services, but also just better aligning care coordination. That I think from what we've seen, I might be speaking from my own personal experience, is that some of these platforms, like that's not a role that they fill very well. They do the referral piece, decently well. And so I think that we're trying to really think about like what are all the use cases that might be needed, so that we're not developing one system for referrals, one system for care coordination, one system for because I think, and I see the comment in the chat too, like there's already, I think, like dual entry happening for a lot of programs, even the ones that are using some of the platforms. They're using one for their own internal record keeping, and then they're using another one for the referral. And I think hopefully the ultimate goal is we can make this as easy. It's going to be complicated to get there, but I think the end result being as easy as possible for people to access, to use it, again, to lend to that larger picture of, community care planning and coordination as a state. Thank you for those comments.
I was in a healthcare provider's office who was trying to get a jump start on social determinants of health screening and referral just a few months ago, and they were totally manual. I mean, they were using a whiteboard to survey somebody, and then they had a little binder of resources, and I mean, they weren't using any electronic platform, and I was kind of in, oh, we're leaving. But anyway, I was kind of impressed that, with that office for their initiative, number one, and it also kind of showed me that you could do this on a very low scale. You can identify in your zip codes and communities what resources are available and just start on something.
Thanks so much, David. Sorry, go ahead, Patty.
It looks like we've got 26 seconds, but thank you both, Caitlin and Anna. And yes, we'll leave it with your final words, Anna.
I just want to thank everyone for your engagement and for attending this breakout session. We'd love to hear any thoughts or feedback you might have in the future, so feel free to reach out. Thanks again.